All right, so this is the last session in terms of lumbar radiculopathy from a disc herniation is concerned. We're going to talk about treatment. So typically for patients who have lumbar disc herniation, we'll start off with treating them without surgery, which includes using anti-inflammatory medications, using muscle relaxants to try to control their pain. Sometimes a very short course of opioid medications. You really have to limit it to less than 2 or 3 days. And oral steroids. So oral steroids, why are they useful? Well, they can calm down the inflammation, calm down the aggravation, help with the pain. That's usually the initial treatment for that. If it's really acute, if they just started having pain, I'll even tell the patients to do a day or two of bed rest in the beginning to calm things down. Once their pain is a little bit better, we'll have them start physical therapy. And the type of physical therapy depends on the therapist you go to. Different methods are used there, but they will generally employ a combination of stretching, traction, trying to find different maneuvers that relieve the pain. McKenzie physical therapy is a specific type that is considered to be useful for patients with radiculopathy. Now, for patients who are not improving despite these treatment, the next step that I'll typically take is to send them for an epidural injection. The epidural injection, again, it's a steroid injection. The goal of the injection is not that it's going to somehow remove the herniation. The goal is that with the steroids injected or targeted at the source of the pain, we can calm down the inflammation and try to help the pain. And what we are trying to do with all these different maneuvers is essentially we're trying to buy time. We're trying to have the pain under control and give the body a chance to heal itself, which luckily in up to 90% of cases, we do see that the symptoms of radiculopathy can improve significantly within the first 6 weeks to 3 months. And especially for patients who have a large fragment that comes out that's extruded or sequestered, they do have a higher chance of things improving with non-operative treatment given time, as long as they don't have significant weakness. If they have significant weakness, that's different. So for patients who improve with non-surgical treatment, which is close to 90% of patients, they improve, they're fine. When they don't improve despite non-operative treatment and it's been 6 weeks or more, that's when we start to talk about surgery. The other time we talk about surgery is for patients who have a lot of weakness, because when they have weakness, it gets a bit more tricky. You don't want to sit and wait for someone who has a lot of weakness for that weakness to then potentially get worse. The timing of the surgery. So anyway, this is the situation where we will consider surgical treatment. Usually surgery for these cases is a microdiscectomy. Okay. The timing of surgery depends on whether or not they have weakness and whether or not they have symptoms of cauda equina. If they have symptoms of cauda equina syndrome, which means they have lost control of their bowel or bladder and they have severe pain, these patients have to have surgery within 48 hours of onset of the symptoms to get the best outcome. Ideally, even within 24 hours. Now, for patients who do not have a lot of weakness or maybe a mild weakness and mainly have pain, that's and I consider that a semi-urgent thing. I'd give those patients closer to 6 weeks or so to see if their weakness is improving or not. If not improving, then we operate on them. And the last category of patients who have no weakness, essentially have pain. For those patients, I tend to wait closer to somewhere between 6 weeks to 3 months before we talk about surgery. And some of it is also then dependent on the patient themselves. If they can tolerate the pain and they're willing to give it more time, we can give it more time. So what are the results of surgical versus non-operative treatment? Well, number one, we know that 90% of patients will improve without surgery within the first 6 weeks to 3 months. Okay. Now the sports study showed us that for patients who are not improving without surgery, let's say it's been 3 months and they have not improved without surgery, for those patients, surgery has a better outcome. So essentially, if you symptoms don't improve within the first 6 weeks or 3 months, at that point, now surgery typically will help the symptoms more than continuing with non-surgical treatment. And even up to 4 years, that was shown that these people do better with surgery in all outcomes, except for work status. Work status was kind of similar between patients who had surgery versus those who did not have surgery. And even up to 8 years, these patients who had surgery maintained their good outcome. We also saw that there are some characteristics that are associated with improvement with surgery. So patients who over the age of 41, patients who do not have other joint problems, patients who actually have high school education or less, patients who do not have workers' compensations, patients who had symptoms for more than 6 months, those who were married, those who had worsening symptoms, and those who had mental component score less than 35. These are patients who did better with surgery compared to non-operative treatment. Now, the duration of surgery is a tricky one because duration for more than 6 months, overall, these patients did a lot better with surgery compared to those who did not have surgery. But if you did surgery on them before 6 months, they did even better. So after 6 months, there's a clear big difference between operative versus non-op. But before 6 months, they actually have better improvement with surgery as well. So kind of taking all this into account, typically the sweet spot that I consider for surgery is patients who have had symptoms for more than 6 weeks, but I try not to delay it for more than 6 months. Okay, workers' compensation. Workers' compensation is a different category. Again, from many studies are showing this, and what we know is that the people who have workers' compensation with the same problem, unfortunately, they do see less improvement in pain. They do see less improvement in their quality of life, even with surgery, and they're just less satisfied overall. And typically, now they do see a benefit from surgery, just not as much as those who do not have workers' comp. But by about 2 years, the benefit of surgery in this specific population diminishes and becomes similar to those who did not have surgery. So workers' compensation is very different. Initially, they will have benefit not as much as those who do not have surgery, and then eventually by 2 years, they become similar to those who have not had surgery. Despite all of this, the return to work for workers' comp and non-workers' comp is similar. Now, who are the patients who do best from surgery in addition to things that we talked about? Well, it's really for patients, in addition to everything, patients who do the best are those whose symptoms also correlate with the imaging, right? So if someone comes in and sees me for a pain that's going from the buttock all the way down their posterior thigh, and towards the calf and into the dorsum of the foot. So essentially he has L5 pain, and I look at the MRI scan and it shows a disc herniation that corresponds to the L5 pain. I think that patient is going to do quite well. Now, on the other hand, if someone comes to me with the same pain but also has pain all over their back and in the other leg and in their neck, that patient probably is not going to do as well from surgery as someone who has a very specific pain related to the disc herniation. Now, once you decide on doing surgery for these patients, there are different options for surgery. You can do a mini open microdiscectomy. We can do a minimally invasive microdiscectomy using tubular retractors. There really is no difference between the outcomes. No one's been able to show that a tubular retractor is better than a mini open one. It's essentially, for me, it's based on the patient's body habitus, and it's based on the anatomy of the patient. In some cases, I find that tubular works well, and in some cases you do a mini open to do what you need to do. But there are two main types of approaches in terms of the surgical anatomy. Okay, if a patient has a paracentral disc herniation, which is shown here, which is this one, typically, for this patient, if you can either come midline or you can come with the tubular retractor to the side here, but the goal is that eventually you're removing a part of the lamina and ligamentum flavum to get down to the disc and remove the disc fragment. For patients who have a foraminal or extraforaminal disc herniation, as is shown in the second one here, these patients will often do a far lateral approach, which basically is an approach between the longissimus and the multifidus muscle. So it's really this plane that we approach it. And so essentially what you end up seeing is the retractors expose this outer part of the anatomy. We're looking at the transverse processes, the pars, and the superior facet. And basically this is the corner you're working on to get to the foraminal or far lateral disc herniation.